Assalamu alaikum, ladies and gentlemen. On behalf of Pakistan Society of Internal Medicine, I welcome you to the Atherosclerotic Cardiovascular Disease Course 2021. My name is Somya Iqtidar and I am the Secretary General for Pakistan Society of Internal Medicine, and I am working in the capacity of Associate Professor at King Edward Medical University, and I will be the moderator of today's session. This course is a brainchild of Pakistan Society of Internal Medicine and executed very well by Senior Vice President PSIM, Professor Tariq Wasim, who has been very passionate to introduce preventive cardiology in Pakistan. Our last session was about cardiovascular risk assessment. It was very well attended with about 300 people joining online and more than 2,000 people on Facebook. Thank you for such a brilliant response. Today's module is on lifestyle medicine. Lifestyle is one of the major determining factors concerning the health conditions of a population. The higher percentage of medical consultations in primary and specialist healthcare are due to lifestyle-related diseases, which include diabetes, hypertension, and atherosclerotic cardiovascular disease, and are preventable. Likewise, the great majority of practice guidelines recommend lifestyle change as the first line of treatment. Therefore, lifestyle is not only a public health issue, but also clinically relevant in the current therapeutic management of illnesses, especially chronic pathologies, as I mentioned earlier, diabetes, hypertension, and atherosclerotic cardiovascular disease. This course of lifestyle medicine seeks to resolve the current shortcomings and provide continuity between preventive medicine and current patient-centered clinical practice. We have a wonderful lineup of esteemed panelists today, and it's my utmost honor and privilege to introduce you to the experts in the field of medicine, cardiology, diabetology, nutrition, which all involves what we call lifestyle medicine. On my right is sitting Professor Nadeem Hayat Malik. He's a renowned interventional cardiologist of the country. He's been the chief of cardiology at Punjab Institute of Cardiology, which is the biggest cardiology institute in Punjab. He's the pioneer in setting up a preventive cardiology setup in his very institute, and we are really honored to have him as a faculty of our course today. Welcome, sir. Next to Professor Malik is a man who I call the perfectionist, because whatever assignment he undertakes, he completes it with utmost perfection. He's the National Chair of Diabetes of Pakistan Society of Internal Medicine, Professor of Medicine and Diabetology with a vast experience of dealing with patients of chronic ailments, especially complicated diabetes mellitus. Thank you, Professor Zaman Sheikh, for traveling all the way from Karachi to join the ASCVD course 2021. Next to Professor Zaman Sheikh is a man who is my mentor. He's a physician par excellence, a great clinician, and a wonderful teacher. Professor Sajid Ubaidullah is working as Professor of Medicine and Associate Dean, King Edward Medical College. He's also the Vice President, Punjab of Pakistan Society of Internal Medicine. Thank you, sir, for joining us. We will also be joined by Dr. Shehla Javed Akram. She's an entrepreneur, a woman leader, a clinician with a post-graduation in nutrition and dietetics, and a practicing nutritionist who will be giving her tips about nutritional management in the lifestyle medicine course. Ladies and gentlemen, our speaker for today has a very difficult task, but I'm sure that with her wisdom and intellect, she will make this challenging topic easy to understand, and she will make us wiser and healthier with her pearls of wisdom, which she's going to share from her knowledge and experience. Our speaker for today is Dr. Khadija Irfan. She's Associate Professor of Endocrinology and in charge diabetic clinics at Services Institute of Medical Sciences. Dr. Khadija is going to talk about healthy eating and lifestyle interventions before and after heart disease. Dr. Khadija Irfan, please.
Thank you very much. Assalamu alaikum, everybody. Thank you for the kind introduction, Dr. Somya. And thank you for all the renowned faculty who are here and are sparing the time to listen to me talk. So today, as you said, Somya, it is a very difficult topic in that its implementation is difficult. In fact, it is the essential and the core aspect of any management lifestyle modification. So we are going to be talking about lifestyle modification for primary prevention of atherosclerotic cardiovascular disease. And that's a mouthful. So from now onwards, I will be referring it to only as ASCVD. Okay. Today's talk, I'm going to touch upon what has been covered in the first session. So a little bit about the levels of preventive action, atherosclerotic cardiovascular disease risk factors, then the importance of lifestyle management, and then the various aspects of lifestyle management we are going to be talking about, including weight control, dietary interventions, exercise, and then I would touch on sleep, smoking, before the experts take on these topics in greater detail in their subsequent sections. And most importantly, I would like to talk about the barriers to change, what makes it hard for us to implement lifestyle change. Professor Tariq very ably talked about the disease burden, and he told everybody that 17 million people die each year because of ASCVD. The majority of these deaths occur in developing countries like Pakistan. And these countries are already overburdened by the burden of infectious disease and other critical crises. And therefore, this additional burden is very difficult for these economies to handle. ASCVD cannot be cured, but it can be treated, as all our cardiologists here will bear with me. But most importantly, it can be prevented. And today's theme is about prevention. Professor Tariq also talked about the levels of prevention, and this basically goes from primordial prevention to primary prevention, secondary prevention, and then tertiary prevention. Basically, primordial prevention is risk aversion, where risk hasn't actually occurred and you are making that some efforts to avert that risk. Primary prevention talks about risk modulation. Secondary prevention talks about retarding disease progression, whereas tertiary prevention is preventing the morbidity due to the complications. CV risk factors, some of them you're born with, some of them you can do something about. The ones which you're born with and you cannot do something about are called non-modifiable risk factors, whereas the modifiable risk factors include diabetes, hypertension, dyslipidemia, smoking, central obesity, and then diet and lifestyle. We will be talking about these modifiable risk factors today. The strategies for primary prevention include lifestyle modification, which is our main theme of the talk, but also there are pharmacological interventions as well as surgical interventions, which will be covered in subsequent sessions. So talking about lifestyle modification for ASCVD. Lifestyle is a blanket term. It consists of so many things, so beginning with weight management to diet and exercise, controlling of smoking and additional risk factors such as alcohol, then managing the salt in the diet, and then managing stress and sleep. And there are other also modifiable factors which affect the lifestyle. So let's first talk about weight maintenance. What is an ideal body weight? Now that is a difficult question. And I will now like to discuss a very famous study which is published in the NEJM. And this focused on the relationship between BMI and mortality. And this basically highlighted that there is a J-shaped association between the mortality on the one hand and the BMI, with an ideal BMI lying somewhere between 22 to 22.5 to 24.9. Now, this was a study which was conducted in white Caucasian adults. Was this specifically only relevant to them? No, in fact, not. Because sometime later, a study was done across 4 continents in which it was found that across a range of ethnicities, a range of geographical locations, the same pattern was seen. There was a dip in the cardiovascular mortality between the BMI of between 22.5 to less than 25, and these might be considered the ideal body mass index. Now, some time ago, there was another study which made a lot of got a lot of media attention, and this said that actually there was this study, if I point in this section here, that you would see that they say that in the overweight category between 25 to 30 BMI, there's actually a negative association of deaths with BMI. Now, what does that mean? Does that mean that overweight is protective against mortality? No. Although this was a very major study, published in a very respectable journal, but it had essential flaws. And the most important flaw here was that the normal weight group, which showed an increased mortality, in fact had higher representation of people who smoked and who had cancers, leading to a skewed results. So I think that the important lesson I want everybody to take here is that all those media news articles you see all the time in which you talk about that by overweight is predictive of mortality, those are not based upon reliable evidence. The evidence still says that mortality increases with obesity. The challenge here is maintaining the weight. Now, most adults, if you look at the people here in this room, they are all very lean, so perhaps not for them, but most adults gain weight at a rate of about 1 to 2 pounds each year. And the Nurses' Health Study, which is a very large preventative study, which young women were followed through their careers, in that it was seen that women as well as men who gained about 10 kilos after the age of 20 were 3 times more likely to develop CVD, hypertension, and type 2 diabetes than those who did not. So this is very important. And this is why stopping and preventing weight gain, which is something, a relentless thing which happens in our life, this should be a priority in lifestyle medicine. We should be focusing on preventing weight gain right from the youth, from age 20 onwards. Now, coming to the next part of my talk, which is a major part, in fact, is dietary interventions. Now, Dr. Soumya talked about before and after. So in fact, the impact of dietary composition is consistent for primordial, primary, and secondary prevention. And the same factors which reduce CVD incidence in the primary prevention are also important for secondary prevention among those who had a CVD event. Then the next question is which diet? And there is a plethora of diets. There are the low-carb diets, the low-fat diets, the keto, DASH, plant-based, Mediterranean, and Paleolithic diets. And people are very confused about them. Now, the important thing to remember here is, and this is a figure on which I would like you to look. It's a small print, but it is legible. So this vertical line which goes through the center of this page basically is where the risk is equivalent, which we say that there is neither here nor there. The foods which show up on the left side of the screen are those which are protective, and the foods which show on the right side of the screen are those which are adverse. And they are very simple. By and far, the biggest leader in this, the biggest bad thing is the processed meats. All your nuggets and sausages are there, and also your burger patties. And then the sugar sweetened drinks. And then also the processed grains, such as your refined carbohydrates, and then in general, a Western pattern of that. These are all those which add to the cardiovascular risk. Whereas foods such as fresh fruit, vegetables, nuts, and lean meats such as fish are protective, as are whole grain. And interestingly, among the beverages, green tea and coffee are protective. More so coffee when consumed in moderation than coffee when consumed in excess, but still they are protective. That brings us back to which diet. So let's try to organize these diets in some way. In general, diets can be categorized in those diets which are with low carb, and these compensate for the low carb content by increasing the fat content, among them the Atkins, the South Beach, the Dukan, the ketogenic diets. And then the fats which are low fat and calorie restricted diets. And these include the DASH, Weight Watchers, plant-based diets. And then there are the fats, the diets which include some fat in the content, and these are the good fat. So they take the best of both the previous types of diet and make a third type of diet, which I can roughly call the good fat diet. So coming to the low fat diet. Now, there is no definition for what exactly is a low-carb diet. But arbitrarily, you can say diets which have less than 30% of calories from carbohydrates can be considered low-carb. And to put it in perspective, the USDA food pyramid recommends 66% of calories from carbs. This halves that. But when the calories aren't coming from carbs, where are they coming from? They are coming from fats. So these have that. Now, this gentleman is the person who first set the ball rolling. And this best-selling novel I can call it a novel because as interesting as a novel is the Dr. Atkins' New Diet Revolution. And this changed things for a lot of people who suddenly went on to Atkins. But for a long time, Atkins was just something which came out of fashion magazines and people in the high society were doing it. But what actually did it do? Was there a physiological basis? And in fact, yes, there was. So if you look at the low-carb diet, basically works through reducing the insulin levels in the blood. Now, as you know, insulin is a lipogenic hormone which increases the percentage of fat which is stored in the body. When this is cut short, then there is a consequent weight loss. And at the same time, a deficiency of insulin increases lipolysis. And when it increases lipolysis, again, that contributes to weight loss. But at the same time, lipolysis and beta oxidation of fatty acids leads to the production of keto acids. And this ketogenesis is the essential component of low-carb diets. And these keto acids then suppress the appetite. And if you have ever met anybody who's ever gone on a low-carb diet, they would say the appetite goes. And the appetite goes because of these increased keto acids. Remember, these diets don't send a person into ketoacidosis, they just send the patient into ketosis. So they stop short of frank ketoacidosis. So as I said, for a long time, low-fat diets were the stuff of fashion magazines. Then came along this study. This was a very seminal study published in New England Journal of Medicine again. And here they compared 3 types of diets: a low-carbohydrate diet, a low-fat diet, and the Mediterranean diet. And if you see in blue here is a low-carbohydrate diet. In initial weight loss, as well as maintenance of this weight over a period of 2 years, clearly it was a winner, excuse me, above all other diets. So suddenly, the low-carb diets were out of the fashion magazines into science. It was concluded in this study that low-carb and Mediterranean diets are superior to the low-fat diet, which is a cornerstone of health prescription in all over the world. And not just in weight reduction, they also had very beneficial effect on the lipid profile. And this is where the cardiologists are so very interested because this is what matters to them. Was this the only thing? No, there was another study. Now, this is called the A to Z study. This was a shorter period trial. And what they did was that they compared a range of carbohydrate intakes from very low carbohydrate to low carbohydrate, higher carbohydrate to the very high carbohydrate diets. And studying these ranges, they found something very interesting, that there is not a continuous progression of effect of weight loss across these. It is only the very low carbohydrate diet, which is the Atkins diet, which is marked by the triangular graph right at the bottom, are those which are causing weight loss. The others, the zone diet, the learn diet, the Ornish diet, are more or less comparable. So basically what we learned from this study is that the very low carbohydrate diet is actually what is working. Now, Atkins was a diet which was full of fat and full of animal protein. And cardiologists have a big morbid fear of these two things, I'm sure. So somebody came up with something called an eco-Atkins, which is a vegetable-based Atkins. And this study of the eco-Atkins diet, in which they compared a low-carbohydrate vegetarian diet versus a high. Now, most vegetarian diets, as you all know, are loaded with carbohydrates. So they compared the standard vegetarian diet, which contained a lot of carbohydrates, to the low-carbohydrate variety, and found that while the weight loss was there, weight loss was there for both the types of diet, the vegetarian, which had a low-carb content, and the vegetarian diet, which had a higher carb content. But the lipid profile was much better for the low-carb vegetarian diet. The same theme going on, that low-carb works miracles for lipids. A typical low-carb diet plan, and Dr. Shella is here. She's going to be talking about diet plans in the future, so I'll let that be for now. And we will move on to the second category of diets. These are the low-fat, calorie-restricted diets. Remember, these were the first and the foremost what we started. Now they target, this is a simple equation. They target calories by targeting the worst offender for calories, which are fat calories. And like in the low-carb diet, there is no one definition for that. There is also no one definition for what constitutes a low-calorie diet. But typically, a low-fat diet contains less than 30% of calories from fat. Now, this is rather arbitrary, but what is rather fixed is that all the low-fat diets emphasize that less than 7 to 10% of these calories should come from saturated fat. Now, there's too much literature to cover. A huge body of literature supports evidence. Now, this is like where we started as lifestyle doctors when we were talking about what to do to manage weight. So the problem here is that for most people, sustaining a calorie restricted diet is almost impossible. And the majority of the weight loss trials, they just have a huge unacceptable number of dropouts, and people just simply cannot comply. Then the question is, the big thing people say is a calorie is a calorie. Calorie comes from fat, calorie is a calorie. You just need to count calories. But the important thing, the lesson we have learned from all this is that it is the quality of the calories. The high quality foods, including unrefined grains, including fruits and vegetables, including healthy fats and healthy source of protein, are protective, whereas the lower quality foods, they contain refined carbs, which contain sugars, and saturated fats are unhealthy. So it's the quality which matters. In a low-fat diet, typically the sources of fat, such as butter, margarine, etc., are limited. Also, fried food are limited, and red meat, as it contains very high quantity of fat built into the structure of red meat. And it also advocates for avoidance of sugary drinks, as well as sugary foods and also alcohol. The sample diet chart again, I'll leave for Dr. Sheila. The next diet, which is close to the cardiologist's heart, the favorite of all cardiologists, is a DASH diet. Now, this is called Dietary Approaches to Stop Hypertension, which is very close to the low-fat diet with important differences. Now, it's called DASH because it was based upon the DASH trial. And the reason why it's so favorite with the cardiologists is because it was launched in the cardiologist conference. Now, the DASH diet, like the low-fat diet, is low in saturated and trans fats. It is rich in the whole grains. It emphasizes the lean sources of protein. But where it differs, it is lower in sodium. It has sodium targets and it focuses on them, and rich in potassium. Now, DASH diet doesn't have a fixed diet plan. Instead, it's not a prescriptive diet. It sets you goals and you have to stay within goals. And it targets for a moderate degree of calorie or no calorie restriction. Now, in the DASH trial, they compared this diet with standard American diet and a vegetarian diet. And you see the one right below the bottommost is this figure shows the drop in blood pressure. And the bottom line in both the graphs is the systolic and the diastolic blood pressure. And you see that the DASH diet has remarkable effect on the blood pressure lowering. They took it on to establish what is the right sodium level. And for that, they did something called the DASH sodium trial, in which they tested out 3 different sodium levels: the high sodium, the medium sodium, and the low sodium. And they found here that across these 3 levels of sodium, there's a consistent and a maintained weight reduction in blood pressure. So this is very important, that these emphasize that the lower the sodium, the better. And in fact, the last level has a level of only about 1,300 milligrams of sodium per day, which is very low. So in summary, DASH has weight loss, blood pressure reduction. It also lowers uric acid and reduces the risk of insulin, ASCVD, type 2 diabetes, and CKD. The DASH eating plan is not a prescriptive, rather it gives a weekly and a daily goal of what to include, and in particular has a goal of sodium. Okay. This is a DASH diet plan. Then the Mediterranean diet. Now, this is very famous and very favorite with a lot of the people who like to have some fat in their diet. And this basically is primarily a plant-based diet, which emphasizes whole grain. And it's relatively restricted in animal protein content. And these animal proteins are fish and seafood based. Again, like the DASH diet, it is not prescriptive. It does not specify portion sizes, and lets the person have some freedom. Now, this study published in the in JAMA also suggested that women who followed this Mediterranean diet had a 1/4 reduction in the risk of developing ASCVD over the course of 12 years. Again, another study, a primary care study, showed that this diet reduced the rate of death from stroke and diabetes. And again, this shows that this is the same thing is shown graphically. So the pros of this diet are slows aging, slows decline of cognitive function, reduces the risk of type 2 diabetes and cardiovascular disease, and prevents cellular damage. But the pitfalls are, because it is not a prescriptive diet, it can run the risk of excess calorie intake, and because you're allowing nuts and fats, somebody can end up having too much of these. And then as you know, is not a good thing. This is the meal plan. Again, I will leave that for Dr. Shaila. Now, talking about lifestyle change barriers, why lifestyle change does not manage well. Now, I want you to focus on the orange bar in the middle of the slide. These are what make people ingest a poor quality diet. First of all, people don't know what is important. Then sometimes good diets are simply not available. Where they work, where they have their meal at the cafeteria, good diet is not available. And then you would see that healthy food choices are expensive. You ask somebody to have fish and nuts and protein, you're adding, and apples, you're adding substantially to their monthly budget. Then people who cannot cook for their own selves, they have scarcity of time, they'd rather have something on the go and take a fast food. And then the cultural norms, such as people in our country would like to have food which looks slightly, glossy. And then there is the industry which markets these things so aggressively, equates Coca-Cola with happiness, equates, fatty food with the ultimate enjoyment of life. That's where we are. And to be honest, fat adds to the flavor. So taste and flavor is a thing. How do you overcome these barriers? The most important here is socioeconomic disparities, because in low-income families, a good food choice is sometimes a luxury rather than a reality. They cannot afford that. But where there is a will, there's a way. So there have been solutions in many countries where they have provided nutritional assistance programs to low-income women and children to improve their diet quality. Again, healthy school meals are also another option where this thing is being practiced. Then there is the challenge of the industry. The industry promotes unhealthy food, and they push back against regulation. If you try to get regulation of food labeling saying this food has too much fat content, it should come with a warning label, they would just simply refuse to accept that. They will aggressively campaign to get these things overturned. The solution is to inform the consumers. When the consumers will step back from taking these foods, the industry will have to follow suit. They will self-regulate their content. And you have to fight misinformation. I'm sure all of us have seen something like this promoting a saturated fat-laden thing for children, apparently claiming that it makes them grow. So we have to fight misinformation. Exercise, do I have time, Dr. Somya? Okay, I do. I'll just touch on exercise because I do know that Dr. Azeem is going to be talking about exercise in details. Let's just talk. Exercise is protective. It protects through a series of mechanisms acting at the physiological level. It reduces arterial pressure and heart rate. It increases blood flow, causes vasodilatation, decreases inflammation, and thus promotes vascular health. Now, these are recommendations from the American College of Cardiologists Guideline for Primary Prevention. And they recommend that adults should engage in at least 150 minutes per week or at least 30 minutes per day for at least 5 days a week of accumulated moderate intensity exercise. And this is aerobic exercise. Or for those who can go for vigorous intensity exercise, they recommend 75 minutes. Now, examples of aerobic activity are those which make you breathe faster, but the thing is that you should not be so breathless that you can't talk. That's a criterion. So examples are walking, cycling, hiking, even dancing. These all come under the category of aerobic activity. Now, sometimes these targets cannot be met. Somebody doesn't have the time, or they are simply not fit enough to do 150 minutes per week. So the lesson which the ACC is giving it, even some activity, even if it doesn't meet these criteria and these levels, is beneficial. So something is better than nothing. And you have to actively decrease the sedentary behavior in which you are seated for at least half an hour at a stretch. Now, the example of vigorous activity, exercise, or jogging, running, and biking, and this for a relatively shorter period of time have greater benefit. Now, if one doesn't have half an hour at a stretch, you can even divide the entire activity schedule across a day. And something which I tell my patients is that हर नमाज के बाद आप 10 मिनट के लिए चल लिया करें, 10 तस्बीहां पढ़ लिया करें, चल के तस्बीह पढ़ा करें. And this is surprisingly very, very effective. People are ready to take that. Maybe they think Allah Ta'ala ke paas sawab bhi mil jayega saathi, but they do that. Now, the thing is, exercise needs to be fun. If exercise is a prescription, if exercise is a pill, it's very hard to swallow. But if exercise is fun, you have exercise, you're playing with your children, you're playing badminton with your daughter, or you're playing football, that's fun. That is sustainable. But if exercise is like slogging away on a treadmill, that's not fun. So now, a lot of our patients are older, and we need to know that exercise actually counteracts age-related changes in muscle function. It improves their cognitive function, and it is important to start, and it's never too late to start. And for the elders, the same recommendations are there from the AHA. But the important thing is, if somebody has been sedentary for a long period of time, they should go through a graded escalation program, and they should have an evaluation through a cardiologist before they do that. And then stress training. This is very important, the strength training, because these activities are important for muscle preservation. We lose muscle as we go older, and we should encourage strength training for at least twice a week for these people, again, under supervision and with low weights, emphasizing more on repetition and less on weights. And this is something else, flexibility training. Now, as you know, older people generally tend to lose their balance and they tend to have falls. And this is very, very serious, because an elderly person who falls goes into a whole new paradigm of health issues, which we want to avoid. So for that, there's something called Tai Chi. Now, this is a very beautiful form of exercise in which there is a very slow, very graded movement. It is derived from a form of martial arts. So these are postures. If anybody remembers seeing Karate Kid, a lot of Tai Chi was there. So this is a system of movements and slow movements, and it improves balance and flexibility. And not just that, there are studies which have shown that it reduces the incidence of ASCVD, and it improves the weight, the BMI, and therefore this is a very good thing to start for that. So there is a big range of things which can be done. The thing is that we need to do them. We need to do our best to encourage the uptake of exercise among our patients. Smoking, I think Dr. Sajid is going to talk about. One thing I want to mention is every visit, every time, ask if you're smoking, tell them they're not to smoke. And then be proactive, do something to stop smoking. And this is something close to my heart. Remember the nurses' health study I talked about right in the beginning, these young, healthy women? And we took them through we followed them through their careers. And in that, it was found that these young women who slept less than 5 hours, and those women who slept 7 hours or more, the women who slept less had a higher incidence of becoming obese compared to those who slept more. Now, this is counterintuitive. Don't you think jo soya rehta hai wo mota hota hai? But no, in fact, a person who sleeps less may be too tired to exercise. A person who sleeps less may be getting up in the middle of the night and binge eating. You might be taking a 4th meal and a 5th meal at the middle of the night. And also, sleep disturbs the key hormones. All your diurnal hormone rhythms are disturbed by sleep. So encouragement of adequate sleep is so very important, and that reduces stress, and that itself is a protective factor in lifestyle. And with that, thank you very much. And I think I am done in time. Thank you, Dr. Sonia.
Dr. Khadija. It was indeed very enlightening. With this, we will move on to our panelists. And first of all, we would like to get advice from Professor Zaman Sheikh about diabetes. Diabetes, ladies and gentlemen, you all know is spreading like an epidemic. 463 million people worldwide are living with diabetes, and most of them are of type 2 diabetes mellitus. And another 374 million are estimated to be high risk of developing diabetes mellitus. And studies from all over the world have shown that changing your lifestyle, modifications in your diet, and a healthy diet and physical activity, they can not only delay the incidence but also prevent the onset of type 2 diabetes mellitus. So diabetes being the mother of all illnesses and a risk factor of many atherosclerotic cardiovascular problems, I would like Professor Zaman to talk about importance of glycemic control, in particularly relation to prevention and rehabilitation of atherosclerotic cardiovascular disease. Dr. Zaman, please.
Thank you very much, Dr. Soumya Akhtar, for your kind introduction. And it was excellent talk by Dr. Khadija Irfan. And I congratulate Professor Tariq Wasim for organizing such a nice course and inviting me from Karachi. And nice to see my co-chairpersons, Professor Nadeem Hayat Malik, Professor Sajid Ubaidullah, and Dr. Shaila Javed Akram, and all other friends. Oh, okay, so I will touch briefly on the metabolic syndrome. If we control, we cardiologists and diabetologists are together here because of metabolic syndrome. Basic problem is visceral obesity, and visceral obesity will cause free fatty acid secretion from the breakdown from the liver, and it is the key pathogenicity in metabolic syndrome leading to type 2 diabetes, atherosclerotic cardiovascular disease, dyslipidemia, and eventually ischemic heart disease and CVA, and is fatal, maybe fatal. So if we prevent metabolic syndrome, then we can prevent all these complications. And to prevent obesity, which is the key name in the metabolic syndrome, is obesity. If we control obesity, then we can prevent all other complications. So many studies have been done to reverse the diabetes to prevent further complication. And direct study is very famous study. And it was done on 300 diabetic obese patients in Newcastle and University of Glasgow. And Taylor was the main author, and Mike Lean was from University of Glasgow. They performed one study on 300 obese type 2 diabetic patient, and they gave 8,000 calories only in 24 hours. So 8,000 calorie in liquid form, either soaps or shakes, to maintain uniformity, because if we allow them to take normal food, then there can be bias. One can take more carbohydrate or less protein. So they gave shakes for first couple of months, only liquid food, and diabetes actually reversed for 2 years, reversed back to normal, and no need of any treatment. And they used actually Newcastle diet. And further study was done by Roy Taylor, the same author of direct study. And the name of the study was Retune study. It is a recent study published in American Diabetic Association journal, Diabetes. And it was done on non-obese type 2 diabetic patient, and same 8,000 calories were given. And in them also type 2 diabetes reversed, because although they were non-obese, but their threshold for pathogenicity was reduced than obese patient, and weight reduction, further weight reduction benefited them as well. So this was the beauty of giving low-calorie diet in type 2 diabetic patient, and we can reverse medically, not surgically by bariatric surgery, medically reverse the type 2 diabetes. Few words about keto diet. Dr. Khadija Irfan mentioned many diets, and keto diet is very famous nowadays, but it is not practical, because nature has given us metabolism of carbohydrate. Our metabolism is based on carbohydrate, because we check blood sugar We don't check serum amino acid. We don't check serum free acid, free fatty acid. So if we switch carbohydrate metabolism to unnatural metabolism like fat and protein, then this may cause some complication. In keto diet, only 50 gram carbohydrate is allowed. 50 gram means 5 simple biscuits in 24 hours or 2 apples, because 1 apple contains 25 gram. So such a low carbohydrate diet, and 20 to 30% protein, and any protein you may eat, even beef, and they use pork as well, or fish. And rest of diet contains fat. So they consumed more fat, but it is abnormal because it led to so many complications like hypercholesterolemia, constipation, hypos, and kidney and liver problem. So keto diet is okay for first few months, but for long term, this is not practicable. About coffee and green tea, they contain antioxidant like polyphenols. So they are beneficial not only for diabetes, also for cholesterol, for hypertension, and to reduce the body weight. So this is beauty of consuming coffee and green tea. But coffee contains caffeine as well. So it is better to use decaffeinated coffee rather than normal coffee to get more benefit out of it. Thank you. The overall recommendation is to keep HbA1c below 5.7%. Between 5.7 to 6.4%, it is pre-diabetic, whether it is fasting, impaired glucose, or impaired glucose tolerance. So if we keep our blood sugar below 5.7%, then hopefully no further complication will occur. And this should be our aim. But if once diabetes occurs, then our aim should be to keep HbA1c below 6.4%, not 5.7%, below 6.4%.
Okay, so next we are going to address another very important aspect of our lifestyle medicine, which is smoking. Smoking, you all know, it's like, I always say, it's like burning yourself. You're not burning the cigarette, you're burning your life. So smoking cessation is a very challenging task. People who smoke, and especially those who smoke, have been smoking for years. It's a very huge challenge to quit smoking. So what help can a doctor provide in smoking cessation? What are the important smoking cessation strategies? And what is the benefit they get out of? And for after how long this reversal of the damage which has been done by smoking, we can see in the body, especially about rehabilitation in the heart disease and coronary artery disease and peripheral vascular disease. To throw light upon this important aspect, I would like to call upon Professor Sajid Abedullah, Professor of Medicine and Vice President, Punjab PSIM.
Thank you so very much, Soumya, for this introduction. And I must congratulate, before starting, Dr. Khadija Irfan for an excellent presentation. I must like to rephrase the topic which is being assigned. Instead of smoking, I will like to throw more light on tobacco, because smoking is just thinking of something like cigarette smoke, but there are a lot of people in the world, more than 320 million till now identified, who are taking tobacco, but not in smoking form, which we call chewable tobaccos. And in this part of the world where we are sitting, it is extremely common, like in the form of pan, tobacco pan, then niswar, it is extremely common here, gutka. These are the tobaccos which we are regularly taking in addition to smoking. And this is the one which is creating a lot of issues in our part of the world. It is common in other areas as well, but Southeast Asia is the part where this chewable tobacco is more taken than else of the world. And this chewable tobacco has two important things which I will like to mention. One, to me, it is more addictive. You can ask someone to quit smoking, but it will be extremely difficult for a person to quit tambaku wala pan or to quit gutka. It is more addictive. And this tobacco, which is absorbed sublingually, it damages blood vessels in the similar way as smoking is. The smoking, which is being done conventionally by cigarettes, but other ways like cigars, like pipes, which are used by elite class, they are also one of the sources of tobacco inhalation. Recently, we are switching from conventional cigarettes to electronic devices. And these electronic devices, although they are using e-fluid, which is containing some nicotine in it, and that nicotine which is being taken is the one which, just like conventional smoking, leads to similar sort of cardiovascular disease as conventional smoking does. Here I will like to say that one very important term, which is secondhand smoking, which we also know as the people who are sitting in the vicinity of smoking areas and they are inhaling smoke, which we call passive smoking, which we also call passive smoking, is also as hazardous as a person who himself is smoking. So that is very important, that if someone is smoking, we should not be accompanying that person just for the sake that he want to talk to you, he want to discuss something with you, and the environment is all full of smoke, because same smoke you are also ingesting. And this smoke, one is the conventional smoke which he inhaled and then exhaled, and also the burning of cigarette around, which is producing smoke, and that is also adding insult to the injury. Cardiovascular disease, which we are discussing now, is having few areas, as Dr. Khadija mentioned, which we cannot modify, but there are modifiable areas in which smoking is one of the most important things. And everybody knows that at least 21% of ischemic heart disease is due to this modifiable risk factor smoking. So if we do any measure to quit smoking, this 21% risk of coronary heart disease may be prevented. How can we overcome this? To overcome this, I think we have to have the personal will, the will of the person. One thing which I always say, लोग कहते हैं कि जी मैं 20 सिगरेट पीता हूं तो 20 से 19 कर लूंगा, 19 से 18 पे आ जाऊंगा, 18 से 14 पे, 14 से कम होता होता मैं बंद कर दूंगा. लेकिन जब वो बेचारा 7 पे पहुंचता है, 6 पहुंचता है, अचानक एक दिन उसको फिर कोई सदमा पहुंचता है किसी की तरफ से, and again he comes back to 20. So if you want to quit, to me, the best thing is that you have quitted once and for all. And then you have to stick to your task. How we can do that? There are a lot of studies on this, that how you can refrain yourself from smoking once you have decided that I won't be taking cigarette again. You should be indulged in more and more healthy activities. You should be exercising. You should be making yourself more busy. You should be avoiding companies of those people, those friends who smoke. So there are a lot of studies on that. And then community can also help, that as we have already seen that in a lot of areas, smoking is not allowed. It is requirement, it is need of the time that more and more such places should be identified and they should be made smoke-free areas. Government may help us in all this regard, because unless policies are made, we all know that smoking is not allowed in airports. Smoking is not allowed in airplanes. So all these things need to be extended to different other areas. And one very important thing which we must emphasize is the role of media is too much. The media must play its role. हम सब जानते हैं कि most of the programs, they are sponsored by the cigarette companies, and there they always say कि cigarette is hazardous, but they run it very very fast forward. सिगरेट नोशी सेहत के लिए मुज़र सेहत है, इससे परहेज करें. तो इतना फास्ट वो करते हैं कि आपको समझ ही नहीं आती कि सिगरेट आपने पीना है कि आपने सिगरेट नहीं पीना. So policies from government that its projection on televisions, on media should be reduced, as well as the government should make plan, if it is possible, that we are increasing taxation on everything. If one thing need to be taxed more and more and more, that is cigarettes. So if taxation is increased on cigarette, probably that will lead to a less number of people who will be smoking because they may not be able to afford it. Can something else help? Like, can nicotine help those people? We know that there are nicotine replacement therapies, there are nicotine gums, there are nicotine patches, there are nicotine lozenges, which are there, which just replace nicotine in relatively low dose, which is relatively less harmful than smoke itself. Are there any drugs which we can use to help quit smoking? Yes, there are few which are available in Pakistan. Like one is bupropion by the name of Xeon, Xylex, Betulin, which we can use in these patients. And this drug is given in a dose 150 milligram once a day for 3 days. Then you can increase it to 150 milligram twice a day for next 12 weeks and see the success of therapy. If there is improvement, you can continue it for next 12 weeks, and then you can decide later on that you should continue this one or not. Again, varenicline, which is available by the name Chantix, that is again one of the drugs which we can recommend, 0.5 milligram daily for 1 to 3 days, and then 0.5 milligram twice a day for day 4 to 6, and then 1 milligram twice a day for around 12 weeks. And again, it may be continued for next 12 weeks if response is getting good. But saying all that, the only one thing which I will again emphasize can easily lead you to quit, although it is very easy for me because I don't smoke, but extremely difficult for a person who smokes, that if you want to smoke, you should be having just a will, कि मैं आज तो बाद cigarette नहीं पीना, and that's it. And once you say this, then you should stick on this. So what advantage may be there if we stop smoking? That was the last thing which was being asked. If anybody quits smoking today, the advantage start from today onward. And after 1 year, the risk of atherosclerotic cardiovascular disease will be reduced to around 20 to 30%. And after 15 years of acquaintance from smoking, the person will be as new as he was when he was not smoking. So this is the advantage of quitting smoking. So it is never too late once you decide that I have to quit smoking. Thank you.
Thank you very much, Professor Sajid Ubaidullah. I think it's time to act now. And as you said, quit now. So I will be summarizing the recommendations from the panelists in the form of a take-home message in the end. But now we will be requesting Professor Nadeem Hayat Malik to throw some light. I always say that do your part, take care of your heart. And to talk about how to take care of our heart, what exercises are recommended for patients of heart disease and to prevent heart disease, and what lifestyle and dietary modifications we need if you are already a patient of cardiac disease, I would like to request Professor Nadeem Hayat Malik to share his views with special emphasis on types of exercises which patients with known cardiac disease or with atherosclerotic cardiovascular disease can undertake.
Bismillahirrahmanirrahim. Thank you very much, Professor Tariq Wasim and Dr. Somia, and a very illuminating talk by Dr. Fatima, of course. Exercise is an extremely important part of rehabilitation of any cardiac patients. And if somebody asks us the question that is there any condition in which exercise should not be done, in practical terms, there are hardly a few conditions which prohibit exercise from being done. So this is, a lot of people, they have this notion that, exercise can lead to arrhythmias or heart failure or angina. So probably best to avoid it. Whereas it's always the other way around, and the risk of actually encountering one of these complications during exercise has been calculated to be extremely low. And there is a list of conditions which are like extreme conditions where cardiac patients are not allowed to exercise, but there are few. And your cardiologist should be able to, figure out which exercises are, recommended. So as my worthy speaker also pointed out, that the types of exercise, they are basically of three types: the balancing exercises, stretching, and flexibility. These are all grouped under one heading, and a typical example is like yoga. So which causes stretching, and you improve your balance. So the next are the commonly called cardio or the aerobic exercises, which involve large muscle groups. And typical examples include walking, jogging, cycling, swimming. So these are the exercises which are called cardio because they are cardio friendly. They basically improve the fitness of our cardiovascular system, and they not only prevent heart disease, but they also, if somebody is a cardiac patient, they will help in developing collateral vessels in the heart, which will improve the circulation, which will improve the functioning of the body itself and facilitate the, functioning of the heart. Now, the third type of exercise, which is known as strength training, or the typical examples include like weight training. They are, quite, they are popular and they should be done, although not necessarily by all cardiac patients and not in a very intense way. So they are the ones which should be started under supervision in patients who have heart disease. Now, the exercise program always should follow three phases, and that's true for cardiac patients before bypass, after bypass, or after angioplasty. The first phase is the warm-up phase, in which you make your body, used to exercise, and that includes a low-intensity start, like you start walking slowly. Then you exercise, you resume your normal pace and do whatever exercise you can do for the next 30 odd minutes. And the last phase, which is again very important, is the cool down phase, which is where your body, heart rate, your respiration, they start to cool down. And don't, just lie down immediately after exercise. That will negate all useful benefits of exercise. So you should sit down, let your breathing come to normal, let your heart rate settle down. That way you will not feel dizzy, or you will not feel, very uncomfortable. You will not have a lot of palpitations or other symptoms which will make you, alarmed. So these are the phases which we should follow in a typical 30 to 35-minute exercise program. Now, in a normal exercise, during a normal exercise program, cardiac patients and even normal people, they will feel slightly short of breath. They will have some palpitations. They will notice an increase in heart rate. But remember that these are physiological changes. These are the things which we expect with exercise. So they will, they will happen, and they are the ones which will gradually make your system adapted to exercise, so you don't, become short of breath at very low intensity exercise. However, if person becomes extremely short of breath, And a crude example might be that if somebody is unable to talk during, unable to talk at all due to shortness of breath, then the exercise should be stopped immediately, and that's a relatively, difficult situation. Or extreme weakness, dizziness, lightheadedness, a fast or irregular heart rate. Similarly, symptoms of angina provoked by exercise like chest pain or jaw pain or pain on the back of the shoulders, then exercise should be stopped and medical advice should be sought. Now, the tips to exercise. One is the relationship with food, because a lot of people unfortunately have this idea that they should walk after dinner. So this is unfortunately untrue, and one should try not to walk for at least 90 minutes after taking food, and that means easily digestible food. If you have taken a heavy meal, then it is better to prolong it even further to 120 minutes. So no exercising after meals, especially for cardiac patients. Then you follow the warm up and cool down phase, and you drink water when thirsty. Don't try to overload yourself with water before and after exercise. Your body will automatically signal you that you should have some water, and then you should stop for a little while and then again start. And then slowly increase the level. Don't try to run marathon within a month. It's not possible. So you have to slowly increase your walking level, slowly increase your stamina, your speed, your intensity. But if somebody is feeling unwell, like has a fever or is feeling unwell, then they should not exercise. And then they should have a variety of exercises, not feel bored down by the same exercise again and again. And some people enjoy walking with friends or with their colleagues, and wear appropriate attire for the weather. It should not be like too warm or too cold. And you have to take care of exercising in the extreme weathers. You should probably not do it too much, and try to make a routine out of it. Now, the cardiac patients, they can basically get confidence that they can start exercising by either having a limited exercise stress test after discharge of when they are discharged following a procedure. They can have a limited exercise test, and there are various protocols for doing that. And these protocols, they will only restore confidence in the patient that they can start off with low intensity exercise, and they will help in rehabilitation, and they will also be a marker for future events as well. And another useful gadget to have is the heart rate watches, or which gadgets which are available these days, which are very useful and which can guide you to the intensity of exercise, which you can gradually build upon, and you can even work out your stamina according to that. So these are very useful gadgets now, which are fairly reliable, and some of the software, they are even FDA approved now. Now, the cardiac rehab programs, they are unfortunately limited in this country, but they should not be. All major institutions, they have to share the responsibility of starting cardiac rehabilitation programs at a national level, and the database should be shared amongst each other for for future references, as well as building up our own national figures, and so that we can compare them amongst institutions and see which one is doing better and how to improve the situation in others. And these cardiac rehabilitation units, they generally comprise of a cardiologist, a nurse, an exercise specialist, dietitian, and a psychologist. And these rehab programs, they actually help the patient become an active member of the society following a procedure, and they also make the person a useful member of the society, give them confidence in their everyday work and their occupation, as well as in their future lives. So most people with heart disease can exercise safely, except for very few conditions which I told you already. Now, after angioplasty, the few tips are that one should start slow, as I've said, just the common question is that when can I start walking after angioplasty? The answer is as soon as you feel ready. So if you had a successful angioplasty procedure, generally we try to make the patient walk before he or she goes home. And I think that is, your own body will tell you that you can, start walking and maybe do 5 or 10-minute sessions twice a day, and then gradually build up on those. And then you can move on to a park or a more intense level of, activity as well. And try to do about 30 minutes, 5 days a week after angioplasty. But the other important thing is to, have an active routine throughout the day. Exercise is not like a what we call as a period of physical activity. This is, this has to be spread throughout the day. You have to keep walking throughout the day. You have to, keep active, gradually climb stairs, so the more active you are throughout the day, it will add up to the stamina and make you, feel better. And you can also track your progress by measuring your steps and other parameters. Similarly, after bypass surgery, whenever you feel that you are up to, walking, start walking, because the earlier you start walking, the better you will feel. And again, you start off with short sessions, 5-10-minute sessions a day, and then gradually build up on those. Now, the most important precaution after bypass surgery is to avoid any, these weight training exercises, especially those which involve the shoulders, because if you put weight on your shoulders, then the sternal bone is stretched, and the stitches, they will cause pain, and there may be, sort of a disability which may last for a long time. So don't do any strength training exercises involving the shoulders for at least 12 weeks after having a sternotomy. And then take frequent breaks, even during a walk. Take 5-10-minute breaks and then start. And most people after a bypass operation, they will say that we feel extremely weak. So, we are, we used to run 5 miles a day, and now we can hardly walk. So the thing is that this is a very normal phenomena. Your body is recovering from a major, event, and it will take some time for it to adjust itself to the new routine. But gradually your stamina will come back, and you will be able to reach almost 95 to 98% of your original capacity. So I think with that, I think I've covered most of the aspects of exercise and how it relates to heart patients. So in the end, again, I would like to, convey the message that do exercise. If you can't do any other exercise, then start walking. And a common, dialogue in the clinics with patients is that when I tell them that how much do you walk, they say that no, we can't walk. We have, knee joint problems. So I tell them that why can't you use the bicycle? And then the patients start laughing and they say, we don't know how to ride a bicycle. So I tell them that this is not the bicycle which we run on the roads, but this is the exercise bicycle, and which is very cheap nowadays. So again, do some exercise for your own self, for the future generation, and keep healthy. This is something which you can do for yourself, which will work much more effectively than any medication or any intervention. Thank you very much.
Thank you very much, Professor Nadeem Hayat Malik, for such useful and practical tips about exercise and post-CABG and post-PCI rehabilitation of heart disease. Next, ladies and gentlemen, we are going to talk about what we eat. And I say that we are what we eat. And it's not only what we eat, but how we eat. and then how we consume it. So to throw light upon this important aspect of prevention of atherosclerotic cardiovascular disease, I would like to invite Dr. Shaila Javed Akram. She will be talking about diet prescription of primary and secondary prevention of atherosclerotic cardiovascular disease and diet before and after a major ASCVD event. Dr. Shaila Javed Akram.
Bismillah ar-Rahman Rahim. Thank you so much, Professor Tariq Wasim, Professor Somia, for inviting me over and on such a high rated gathering. And I would congratulate Dr. Khadija for an excellent presentation. You gave a very nice overview of all the different diets which are there. People are practicing that. And but I have some of the I have a little different idea and approach towards nutritional management of ASCVD. There are two types. I believe there are two types of patients in ASCVD. One group of the patients is who don't need to lose weight, and there's another group of patients who need to lose weight, but diet management or lifestyle management falls for, it applies to both. So the group that doesn't need to lose weight, not everybody is there to lose weight. That group has to be taught more on very intelligent omissions and additions in the diet. They should be like, time must be spent with those people, which we normally don't. And we are more in a practice of distributing these pre-printed diets, whatever we believe, even in the big hospitals. This is what I've seen, that the nutritionist does not come across the patients and they are just given those printed diets, whatever is recommended by the consultant. And what happens is the result of these printed diets is that the patient starts saying, when they come to me, what they say is, जब मैं डाइट कर रहा था तो मैं ये करता था और अब जब मैं डाइट नहीं कर रहा तो मैं ये करता हूँ. That means they have divided their lifestyle, their management of diet into two groups. There is a phase in the year when they are on diet, and then there's a phase when they're not on diet. This is actually not what we are targeting, because ASCVD cannot be cured. That's what I've learned here, and that's what I know. It has to be managed. So the management can't be with two phases in that patient's life, that half of the year he is on diet and half of the year he's not on the diet. He is going to undo whatever he has done. So that is one thing that I strongly believe in that. And every patient, whether they need to lose weight or they don't need to lose weight, these patients have to have a sitting with a consultant, with a nutritionist, so that the nutritionist understands that what is the patient's likes and dislikes. If the patient, if we try to manipulate slightly what the patient is taking, that is more long lasting and the patient understands. And then that is what is meant by lifestyle management and the diet management of that patient, because we try to make him learn and try to give him an idea that what he is going to eliminate and what he should, add in the diet. For example, if you ask these patients who are on those printed diets of Atkins or Mediterranean, that, okay, which foods you should be not taking, which have trans fatty acids, or which foods are you going to take, which gives you protein from plants. They have actually no clue, because they just think that there's a diet which is printed like Atkins, and this is what they're going to do. They increase the proteins, increase the fat, and omit the carbohydrates. And then when this phase is over, they're back to their own diet. So this is what I strongly discourage. Now, when one thing is that I stress that an overview of the ingredients of the diet, which diets, what type of food is friendly with them, which type of food should be avoided, that should be made very clear to the patient, and the patient should be given a choice to adopt what suits him. But from among the list of the food list that we try to explain it to him. The other group is that the same with ASCVD, but who need to lose weight. for that sort of a treatment, what I practice is that there is a weight loss limit that I have to, implement. I try not to go above 0.8 kilograms of weight loss per week. That means 3.2 kilograms per month, because on this weight loss, the rebound is definitely prevented. The rebound is actually, if the patient goes into rebound, that brings more damage than the benefit of the change of diet. So try to keep the weight loss within a lower range, like 0.8, which is recommended by WHO, which actually gives a very smart and smooth weight loss pattern in that patient, and the patient is very comfortable. Now, as far as the calories is concerned, now we after analyzing the diet plan of the patient, that takes about half an hour to analyze what he takes and to understand what he likes. And then what normal practice, what we do is that we then calculate the calories of the intake that he's taking. And unless he's doing really something drastically wrong in the diet, I mean, we have to analyze that. I mean, every diet doesn't mean that whatever he's taking is wrong. So unless there is some drastic changes that we have to make, which we have to explain it to him, what works better is the reduction in the calories. We reduce the calories, we teach him how to reduce the calories and how much calorie loss will give him this sort of a loss in weight. This orientation the patient don't have. If we start telling them that if you, suppose you are taking 2,500 calories and I cut down 500 calories per day, and then I calculate the calories into days, and I tell him that if you are minus 500 per day, you will be losing 1 kilogram in 5 days. So that is the target that is given, and that really works. The patient is very committed because he knows that if he's going to miss 500, he's going to lose 1 kilo. That is like time spending and teaching the patient, which is long lasting and which is very beneficial. Over these years, I've got excellent results with this sort of an intervention, which I give to my patients. Like I cut down the caloric intake of the patient, what he's taking, and I give him an overview of the food which is drastically wrong. I give an idea of what is trans fatty acids, what plant foods he should be taking, how can he increase the vegetables and the fruit in the diet, how can he just not base his diet only on animal proteins, and what are other sources of proteins, and what dairy products he should be taking and what he should be avoiding. So these sorts of this sort of session with that patients is working, and it works with them very well. And I think that is like, but I was I was not given this impression by Dr. Soumya that, like Khadija was saying, that I supposed to present some diet plans, because what I've told is that I actually don't give the printed diet plans. It is one-to-one, it is tailor-made, and it's according to what the patient accepts. Thank you.
Thank you very much. And I think this is the right approach, because everybody has different needs and you need to cater to their requirements individually. We have a very good attendance of our Zoom participants as well. There are more than 200 people who have joined us on Zoom today. I would like to pose few questions to our senior participants, attendees today. Dr. Shehbaz Qureshi, who is also the president of Aspirin Foundation, a very regular member of all the courses. So there's one question, if Professor Shehbaz Qureshi can answer it, that we all know that serum uric acid levels, they have also been attributed as a risk factor for atherosclerotic cardiovascular disease. And we also know that we do not usually treat hyperuricemia unless and until patients are symptomatic or there are very, very high levels. But do we have to keep them at some limit to prevent the risk of ASCVD? This is my question to Professor Shehbaz Qureshi.
Thank you. Thank you very much, Dr. Soumya. It's indeed a pleasure to be on your forum. And I think before I answer your question, let me just congratulate Dr. Khadija for a very good presentation, and all the panelists, Professor Nadeem Hayat Malik, Professor Zaman Sheikh, Sajid Abdullah, Dr. Shaila, for some very good comments. I am glad that I can see Dr. Sajid and Dr. Bilal wear a partially yellow tie on a mental health day, when yellow actually means that it brings sunshine into your mental status. Now, as far as uric acid is concerned, we know very well that it is positively correlated with cardiovascular diseases. It is correlated with hypertension, with atrial fibrillation, with heart failure, and with atherosclerosis. And it is extremely important because, you see, hyperuricemia causes oxidative stress on the endothelium. It causes an endothelial dysfunction. And therefore, it becomes very important that it should be taken into account as a risk factor, and it should be treated. And it should be, now, whether it should be treated with what particular drug, allopurinol, or the latest ones which are there, which one is better, it is still to be debated. Having said that, what I actually think about prevention of atherosclerotic disease, I feel that it is not primary prevention, it is not secondary prevention, it is primordial prevention, which is important. And primordial prevention, actually, what it means is that you start before the development of the risk factors. Once there are risk factors, once the person has already had ischemic heart disease and you are then entering into a secondary prevention, the house is already on fire. And I think in that case, the prevention becomes different. But from the very tender age, from the young age, when the children are toddlers, when they start to walk in the early, I think just even before 5 years, this is the time that you have to intervene, because there is no other way. And then the other thing is that when we are talking about awareness and prevention and diet plans, we are talking about an urban society. We're talking about where people understand what we are talking to them about. What about the rural areas? I think what is needed is that we have to go to the community level. And it is at that level that you have to treat your patients for secondary prevention, for primary prevention, and primordial. And that is the place which is important. Community level intervention. And that is the only way we will be able to reduce the incidence of atherosclerotic cardiovascular disease in our country. Otherwise, as I said, already people have the disease and then it becomes very difficult. And no country's economy can tolerate or treat these patients. It has to be done before the risk factors make their appearance.
Thank you very much, Professor Shehbaz. Indeed, it was very useful. And we must address all the risk factors, like you mentioned, hyperuricemia, if we want to have primordial prevention of atherosclerotic cardiovascular disease. If I can have some comments from our Senior Vice President, Professor Azizur Rahman, if he's online. Professor Aftab Mohsin, Senior Vice President, PSIM, if he is online, we would like some comments from him as well regarding this activity.
Soumya, before Professor Aftab makes a comment, I just want to coin a phrase, and I want this phrase to be, I think, ingrained into our minds. Whether there should be a pill for every ill or whether we should go for lifestyle medicine. The time for lifestyle medicine is now. And that means that physicians also need to actually take care of that. We need to become role models for our patients. The proverb which goes, physician, heal thyself. This is what the meaning is. Self-care first, to become models for our patients so that they follow us. And As far as smoking is concerned, you talked about smoke, but I think the definition of a cigarette, as I always say, is something which has fire at one end and a fool at the other end. And we should not be, and I think this is how we have to educate our patients. And the most important thing is when we are using drugs like bupropion or the other one, it is a bridge to give up smoking. It should not be an alternative. This is what we have to keep in mind.
Okay, thank you very much, sir. You're very right.
Soumya, thank you so much. I am here back from Chitral and I'm so happy that you've given me this opportunity to join you all. All I have to say is, it's wonderful you have made, and just to extend on what Shahbaz Qureshi, my friend, said, I remember a verse which I was quoted to by Amjad Sahab when he visited me, and it belongs to Ghalib. So it goes like this: Lo hum mareeze ishq ke bimar dar hain, अच्छा अगर ना हो तो मसीहा का क्या इलाज? तो मसीहा को भी इलाज की जरूरत पड़ती है, जैसे उन्होंने कहा physicians heal thyself. तो मैं कहता हूँ positive thinking in lifestyle medication is extremely critical, and I would recommend all that जो नदीम हयात मलिक साहब ने कहा, जो खदीजा इरफान साहिबा ने कहा, जो मैम सोमिया ने कहा, जो मैडम शैला जावेद अकरम ने कहा, and my friend Zaman Sheikh, whatever they said, we have to go beyond this. Heal thyself. एक बंदा है जो डिस्पेंजा, you जरूर look up करें उसको. And congratulations Tariq Wasim, you've done wonders and best of luck. Thank you.
Thank you very much, sir, for joining all the way. I am sure you are on way to Lahore from Chitral, and I hope you inaugurated the bridge. Professor Azizur Rahman, Senior Vice President, PSIM, sir, I know you're joining from your clinic. If you can briefly comment on today's module, which is lifestyle medicine. So your mic is mute.
Yes, I think now I'm unmuted, right?
Yes, sir.
First of all, let me compliment my colleague, Dr. Khadija, for a really wonderful presentation. I enjoyed every bit of it. Really, really very useful. And we normally do not talk about these things because we don't find them very romantic, but they are very actually practical. I think she justified the topic very well. I actually have a question. Khadija, are you listening?
Yes, I am.
Khadija?
Yes, she is here, sir.
Okay. Cardiovascular disease and the diet is through our lipids. Now, if somebody has excellent lipid profile without any medication, or he is on some statin therapy and maintains an excellent lipid profile, do you really think that diet really matters in that patient if his lipids are absolutely perfect? Or does any diet component has direct toxic effect on our heart besides this lipid? Khadija?
Yeah, very interesting question, and a question which sort of like goes into the realm of, swimming into those waters which are not properly charted yet. But let's just talk about the fact that it's not just the lipids. It's a matter of, there are multiple things going on. So there is a calorie excess, there is a salt, there is the fact that the diet may contain, as you said, toxic chemicals such as the ceramides and things which actually are injurious to the vasculature itself. So there are, and I think the spirit of your question is that you want to know if somebody is perfectly fine as regards the lipids, should they just forget about the diet? I don't think anybody is in that position in at our age or even in our society, because you do know that as Southeast Asians, we have an inherent increased risk of developing metabolic complications and metabolic syndrome. So for a person who is an equivalent age, equivalent gender, equivalent weight, but is Caucasian, compared to that person, we have a threefold increased risk of developing incident diabetes, incidence ASCVD. So we cannot be casual about your diet. So whether the numbers are telling you perfectly fine, but that doesn't mean that you can just go about and become wild and, you know, go and spend every night eating, you know, the food from Lakshmi Chowk. No, I think that the lesson here is that we need to keep our blood clean and we need to keep our bodies healthy. Because if we do not, as you know, that every year you're gaining about 0.5 to 1 kilo. That is part and parcel of your aging process. So to compensate for that and to be in a good place 20 years from now, you need to be watchful right now. And in fact, for those people who are already at that age at which they are liable, they have one of the non-modifiable risk factors in the form of age, for them, it is even more important to follow a diet which is healthy and is heart healthy and is in general weight healthy. I think that's about it. That's what I can add. Of course.
So that means diet is important irrespective of your lipids and your weight and your glycemic status.
In my opinion, yes. As I said, this is uncharted waters, but yes.
All right, thank you.
Okay, thank you. So there's a question from audience that I would direct to Professor Nadeem Hayat Malik because it's related to exercise and diet regime in a known ischemic heart disease patient with pregnancy.
Pregnancy itself, poses a strain on the cardiovascular system per se, even if somebody doesn't have heart disease. Now, obviously, the severity and the extent of heart disease itself will have a much greater bearing on how much one can do and how well somebody feels during pregnancy and during its various phases. But as a general rule, most people with pregnancy who have well controlled high blood pressure readings and who are not in heart failure or who are suffering from extreme angina, they can probably do some aerobic or cardio friendly exercises like swimming, walking. They are all perfectly acceptable. Remember that in pregnancy, some of the conditions, they do preclude any severe exercise or even moderate level exercise, like somebody having a history of severe hypertension or preeclampsia, similarly uncontrolled arrhythmias and even obstetric conditions like repeated miscarriages with precious pregnancies. So these are the conditions in which exercise needs to be avoided, but otherwise most people should remain active, and probably the most safe form of exercise is walking on a flat ground, not on the stairs or not using steps, because one may tumble and fall on uneven surfaces. And then secondly, one should avoid exercises which involve the abdominal area, especially like jumping or skipping and anything which can lead to movement of the fetus itself. And then thirdly, if somebody feels short of breath, then one should stop immediately, because the normal the exercise capacity will be very much limited, especially with increasing duration of pregnancy and with increasing heart disease severity. So the bottom line is that most people with controlled heart disease, they can do light exercise after consulting their obstetrician and their cardiologist, and they should stay on medication, and they can do short bursts of just aerobic exercise like walking for about 10 minutes twice or thrice a day, which will keep them healthy and mobile and actually help in the future course of pregnancy as well.
Thank you. So we have just 3 questions. I will keep it an open forum, whoever wants to talk about them. The question is, can we as health professionals push the government to reduce the prices of GLP-1 analogs and nicotine patches to quit the smoking? Professor Khalid Khan, he is the chapter
Hello.
head of Lahore chapter PSIM.
First of all, I must congratulate Dr. Khadija, Dr. Somia, Professor Nadeem Hayat, Zaman Sheikh Saab, Sajid Ubaidullah Saab, and Madam Shaila for nice presentation and comments, and warmly congratulate Dr. Tariq Wasim and sir, you as well. I think so. We must ask the government because, as you know, like nowadays, semaglutide price is more than 16,000, and our patient can't afford these medicine, and they are very helpful, especially they help in the control of diabetes, they help in weight reduction, and the price is so much, only elite class can afford these medications. So I think so, you rightly said, we must propose our government or our social welfare department that these medicines should be provided via social welfare department, or government should reduce the price of these medication. With that, thank you.
Okay, another question is, I don't know if anybody can answer it. Is there any simple way to calculate METs during routine exercise? Dr. Shaila or Dr. Khadija? Anyone?
There is a simple way of doing it. You have those charts available in which you know how much energy you burn when you're going up the stairs and what kind of an energy you are burning when you're doing your walks. For example, if you are doing a walk of 30 minutes at a speed which makes you do about 3 kilometers and you weigh about 70 kg of weight, you will burn about 150 calories. And from there, you can get all your other analysis done. Because as far as METs, etc. is concerned, that comes into a different angle. In your previous question, you also asked about the nicotine patches reduction cost, etc. Now, let us be very clear what we are talking about. We are talking about someone who is having a cigarette and wants to quit smoking. So as Professor Saab very kindly said, the real way to commit to whole idea is to actually quit it. Because you cannot quit something which costs you, let's say, 50 rupees and start spending 500 rupees as a substitute to it. So that is not the thing. The only way to quit smoking is that when you just quit it. A very senior colleague of ours and a dear professor of ours, can't take names, he mentioned the other day at the World Heart Day that I used to smoke 2 packs a day. And he stopped the moment he saw his 4.5-year-old daughter smoking. Now, the reason is that you have to remember that fathers don't do a mistake. Baap galti nahi karte. Baap to achhe hote hain. It's a different thing that Mr. XYZ is doing a mistake. So, baap ban ke socho, think of for yourself as a father of your country and father for your children. And that is the way to quit smoking. Thank you.
Thank you. Very beautifully described and very emotionally. And the last question that I will take before we conclude is, intermittent fasting is a very hot debate these days. So experts' comments on, please. Dr. Shaila?
Yes, it is. Intermittent fasting is like being adopted by many of the patients, but I'm still not very sure that what times should we recommend for intermittent fasting, whether it should be that 8/16 formula should be from night and day or from day to night. So that is like very, still I could not find any studies, and I am not very sure that what time slot should we recommend to the patient. If anybody from the group can comment on this.
Actually, although Dr. Shaila is the expert, but a lot of studies, they are now not showing considerable benefit of doing intermittent fasting, because once somebody comes out of the fasting phase, then he or she, they have a tendency to probably overcompensate, and it doesn't cause a lot of benefits which it is touted to be. There is a concept of intermittent fasting in Islam, whereby, you fast for 1 or 2 days a week, which gives the system a rest, and then you sort of retune your body. But unfortunately, it's the total number of calories per day which are more important than taking them at certain times of the day. It is the same debate about having an early dinner or late dinner, or having breakfast or no breakfast. The thing is that if somebody doesn't cut down on the total caloric intake, then fasting for 16 hours a day and then eating for 8 hours is not going to make a lot of benefit. I don't think that a lot of studies, they are now going in favor of this. It is good for our own system and for maybe, some of the scavenging effect which fasting does have on our digestive system. But otherwise, for weight loss purposes, I doubt that it will have a long-term benefit.
Dr. Nadeem, but still, my request was little different. That this gives you a freedom that any slot the patient can adopt 8/16 formula. It can be the night slot, it can be the day slot. So that actually, when most of the people they adopt the night slot, it affects the circadian rhythm of the patient, which is again has a bad effect on the patient metabolism. So that is what I think one of the reasons that I'm not a great, I don't favor this intermittent fasting.
Okay, thank you. Before I conclude the today's session and give you 5 basic tips which I have like a take-home message from all the talks today, I would like Professor Tariq Wasim, who is the course director, to give an overview of the questions and the quiz that we have for this course.
Thank you, Soumya, for very nicely conducting the whole session. As we know, this session was all about lifestyle medicine, and we have already plotted this on the our Google pages, this form which is to be responded by all the participants, and this contains 5 questions based on today's presentations, and of course a feedback, because that's any activity which is an academic activity has to be evaluated. How did we perform, and how did our audience get that message which we wanted to convey to them? So please do visit to that. The link could be shared in your all the emails and all the this proceedings you are getting on. And in previous sessions, we had almost approximately 200 people responding to that feedback, as well as questions which were put, and we'll be sharing that results. And we'll be having this activity after every session. And for those who have to qualify for the certificate, they must attend at least 3 out of these 5 sessions to be eligible to get a course certification. The rest of those who do not follow this routine, they would get a certificate of attendance for each session individually as well. And that would be an e-certificate. Thank you.
Okay, thank you very much. So my take-home messages from today's activity, Dr. Khadija very beautifully told us what lifestyle medicine is all about. And the key message was that we have to shift from processed food, sugar, sweetened drinks, and refined carbs to fresh fruits, lean meat, nuts, green tea, and coffee. So the quality of the food is also important, as well as the quantity of the food. So this is my key message for this. And about the DASH diet, since there are a lot of questions we could not answer, DASH diet not only helps in hypertension control, bringing down the numbers of your blood pressure, but also in weight reduction and insulin resistance and uric acid levels. So overall metabolic profile is better with DASH diet. Dr. Zaman very beautifully told us, he gave us a great news that their diabetes is a reversible disease now. We always used to say it's a chronic ailment, there is no cure for the diabetes, but now we know that diabetes can be reversed, and the key to the diabetes reversal is your weight reduction. And then Professor Sajid Ubaidullah told us about the hazards of smoking, both smokeless and dry and smoking, both dry tobacco and smoking. And I always used to say, which I just recalled, that smoking is the second name of disease, disability, and death. So 1.6 million people in Pakistan, they die because of smoking every year, and 8.6 million people worldwide. So we must cut down, we must quit smoking and say no to tobacco in all forms. Then Professor Nadeem Hayat Malik, his opening line was very catchy. He said, there is no excuse to exercise. Everyone can exercise. There's rarely any condition in which you can't exercise. But there are three phases. You have a warm-up phase in which you walk slowly, then is the exercise phase of 30 minutes, and then the cool-down phase, which is equally important. The message that he gave was that do not overload yourself with food and water before and after exercise, and variety of exercises should be adopted to keep it a fun activity and consistent. After PCI, he said that you can resume exercise as soon as you can, and they usually start people walking before even they discharge the patient from the hospital. And from this, I get the message that sitting is the new smoking. So exercising only 30 minutes in a day is not, that is important, but being active throughout the day is also very active. And we have now smart gadgets to track our activity. You can see your progress, like in the smartwatch that I am carrying today. Then Dr. Shella very nicely put it that diet has to be individualized, and these printed diet plans, which people are asking all over the social media and sharing in WhatsApp group and then trying, is not the right approach. It has to be individualized, keeping in mind the patient's profile, whether they want to reduce weight or whether they want to control their lipid levels. And there are different combinations of diet plans or intermittent fasting, keto diet, DASH diet, Mediterranean diet, low-carb diet, low-fat diet, and it has to be individualized for every person. So I think, ladies and gentlemen, it was a very fruitful discussion, very enriching a module today, and I will thank you all for your wonderful participation and would like to conclude this session with this quote, that a healthy lifestyle is the most potent medicine at your disposal. Have a great evening, and Allah Hafiz.